Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system. So I came across this article on Fox Sports about Darius Morris, who's a former NBA player. He was a 2011 draft pick by the Lakers, and it was no longer in the league, but he was found dead in his home, apparently, of what appeared to be natural causes. And they released his cause of death recently, and it was atherosclerotic heart disease. So he died of a heart attack, died of atherosclerosis, complicated, they said, by polysubstance abuse. I think they found hydrocodone. And then probably the biggest contributor was there was evidence that he'd been using cocaine. So we're going to talk a little bit about that. But mainly I just want to focus on heart disease, and especially heart disease in the young, because this is becoming an increasingly serious problem in our society, obviously, as the entire spectrum of our population gets more and more unhealthy. We're starting to see a lot more early heart disease in people that, previously we would not expect to see such a thing. But what I want to talk about with you guys primarily is some of the screening tests that you can do to determine if you in fact have subclinical atherosclerosis. And spoiler alert, you do. You almost certainly do. And I'll talk to you about some of the three perhaps best validated tests that you can obtain that are relatively easy to get, relatively inexpensive, depending on which one you choose. And then talk about maybe whether you should even consider getting these at all, because there's a case, obviously, to not screen for this and rather just go ahead and treat risk factors. So that's what we're going to talk about today. Coronary artery disease, despite whenever something like this happens, especially if it's a high profile person who's young that dies of coronary artery disease, it always shakes people up a little bit, and it surprises the general public. And it used to surprise me too, but I'm really not surprised by that anymore, because the fact of the matter is we've known for a very, very long time coronary artery disease is shockingly common in young people, especially young men, and we've known this for a long time. As many of you know, I went to a military medical school. I did my all of my medical training through the military, and I remember we talked about this way back in the late '90s. And back then I was a young guy, and I don't think I fully appreciated the magnitude of what we were talking about. And so it kind of went in one ear, out the other. But again, we've known this for a very, very long time. For example, this is from the journal Atherosclerosis. It's back in 1993, but there are studies going back into the 50s. But this one is manifestations of coronary atherosclerosis in young trauma victims, an autopsy study. And I'll just summarize this here. They looked at 111 victims of non-cardiac trauma. So these were just young men who were killed, probably mostly in knife and gun club activities, motor vehicle accidents, etc. Mean age was 26 years old. And here's just the highlighted results. Signs of coronary atherosclerosis were seen in 78.3% of the total study group. 78.3, mean age of 26. So that really got my attention when I read that. With greater than 50% narrowing in 20%. 20%. So 50% narrowing and above. That's when you start having, obviously, potentially having symptoms, especially at high levels of exertion. You start having blood flow compromise, and obviously the risk of rupture is quite high. Rupture leading to heart attacks. Kind of a shocking paper. But I remember we talked about this when I was in medical school, because they have done similar studies on young men who were killed in both the Korean War and the Vietnam War, and it actually paralleled what was found in that study from the 90s in the civilian world, is that there's a shockingly high rate of coronary artery disease. So this is a study way back from 1955, pathogenesis of coronary artery disease in American soldiers killed in Korea. And of course, what did they find? 300 men, average age of 22.1 years. Okay, so even younger than the last study. 77.3% of the cases had some gross evidence of coronary disease that varied from minimal eccentric thickening, so just, very mild coronary artery disease, to complete occlusion of one or more of the main coronary branches. So it ran the whole gamut. I believe in this paper they found roughly 5% of these young men had hemodynamically significant disease in at least one or more vessels, and 1 or 2% of them at least had triple vessel disease. Average age 22. So now I'll ask you this, like, how healthy are the average 22-year-olds in today's society as compared to the average 22-year-olds in the 1950s during the Korean War? So you can see a picture here of these guys in basic training. You know, all of these guys look super fit, with the exception of maybe this guy on the left, maybe slightly less fit. But the rest of these guys look extremely fit. All of these guys have, statistically speaking, the majority of these guys have coronary artery disease already, which is really kind of fascinating to me. So, you know, in my personal experience, the youngest heart attack I've ever taken care of, the youngest heart attack that wasn't directly related to substance abuse, like cocaine, which we'll talk about here in a second, that was just purely from atherosclerotic disease, was 23 years old. And I'll share that story here just briefly with you. So I was actually on my very last deployment. This young man came in, 23 years old, kind of stumbled into our aid station, clutching his chest, looked very dramatic. And you know, I feel a little guilty about it because I kind of raised an eyebrow, like, all right, this looks like some drama here. What's going on? Well, long story short, you know, he was complaining of chest pain. It had been going on for about 15 or 20 minutes. He was just at the chow hall, literally like 100 yards from where I was working. And yeah, we got an EKG, and this is what it looked like. This isn't his EKG, but it might as well have been. So what you'll see here, those of you guys that are medically trained will recognize this immediately as a large inferior ST elevation, myocardial infarctions, big like hyperacute ST elevation here. It leads 2, 3 AVF. We've got some reciprocal changes here in V2, lead 1. AVL, etc., V4. So this is pretty classic, pretty textbook, like any first-year med student can make that diagnosis. You know, again, I feel kind of bad about this because I put on my colonel hat and I grilled this kid really hard about substances because we'd had an issue on the base with guys getting access to, let's just say, illicit substances via the mail and mail order before that loophole was closed. And he just denied. I still had my doubts about that because I just, even though I knew better, I just it was hard to fathom that a 23-year-old could be having, you know, a myocardial infarction that wasn't from vasospasm, you know, where the artery, you know, clamps down. So anyway, long story short, I gave this kid thrombolytics, which is a little bit frightening in a war zone, giving a young guy thrombolytics. Got him on a helicopter and eventually got him up to Germany. He underwent a cardiac cath there, and he had severe disease in his right coronary artery, so severe atherosclerotic disease. I had some of his blood left over, and so we ran it through an analyzer. We couldn't do lipid panels for obvious reasons in that kind of environment, but we were to have the appropriate cartridges to run just like a total cholesterol. And it just said greater than 600. So what this young kid had was FH, familial hyperlipidemia. He's probably homozygous. So he had ridiculously elevated LDL, ridiculously elevated total cholesterol levels. I never heard back from the docs up in Germany ultimately what the rest of his lipid panel looked like. But this guy at the age of 23 had enough exposure to elevated LDL / ApoB that he had developed critical stenosis in his right coronary and had his very first heart attack at age 23. So pretty wild, true story. So now, the scary thing about atherosclerosis, it starts in childhood, which was kind of a revelation to me years ago. So this is a diagram here showing the progression of atherosclerosis. And so, you know, you come into this world with nice, clean, pristine arteries. You have a nice, healthy endothelium. By the way, LDL, ApoB levels in infants are super, super low. We're talking like 20 to 30, respectively. So they come into the world with very low cholesterol, very healthy blood vessels. And as time goes on, you start off with this little fatty streak. You get a little bit of lipid accumulation in the subendothelial space. And as you can see, as time goes on, but that process starts like in early childhood. So it says from the first decade, and that's absolutely right. And as time goes on, I'm not going to get into all the nitty gritty of the, the pathophysiology behind the development of atherosclerosis, but with prolonged exposure to high levels of ApoB containing particles combined with poor endothelial health, chronic inflammation, etc., we have the buildup of this large atherosclerotic plaque, which ultimately, usually after the fourth decade or fifth decade, is prone to rupture. When it ruptures, it exposes all of this sort of collagen and protein-rich necrotic material, and that causes platelet aggregation, and then all of a sudden you go from like a 50% blockage to like 100% blockage, and that's your big heart attack, almost 50% of which are fatal. So first heart attacks, I mean. So really interesting. I typically had thought of atherosclerosis as a disease of older people. And it certainly is more prevalent in older people, but this is a disease that starts in childhood, which is really interesting. So it's all the more important, you guys that have kids. You really need to start thinking about their cardiovascular health when they're toddlers, in my opinion, and not wait until they're much, much older. Now, the other interesting thing about atherosclerosis is this has been with us. This is not a modern disease by any means. It is common in all cultures. It's common in all races, and it's even common in the remains of ancient humans that have been found everywhere in the world. So like mummified remains. This is an article here about Egyptian mummies. And I've reviewed some of this data in the past. High prevalence of atherosclerotic disease in sometimes, remains that are like literally 3,000 years old plus. So this is something that's, in my opinion, is sort of, I think this is an inevitability to a certain extent. So part and parcel with being a human being. That doesn't mean that you have to die of atherosclerosis, but I think it's probably fair to say that none of us will depart the earth here without having some degree of atherosclerosis. There probably has never been a human that has at least made it into adulthood that didn't die with some degree of atherosclerosis. Now, could be wrong on that. There's probably somewhere out there some rare genetic mutations, but even people with like PCSK9 mutations that have ultra low lipid levels, they have very little atherosclerotic disease. They still have a little bit. If they make it into their 80s and 90s, you do an autopsy, there's still going to be a little bit there. Their arteries are not going to be pristine like they were, when they were born. Anyway. Enough on that. Let's talk about cocaine real quick, because it played a role in it obviously played a role in Darius Morris's death, and so I want to touch on that a little bit. I don't see a ton of cocaine related chest pain in my neck of the woods currently. When I was working in Texas and then down in Florida, where there's a lot more like crack cocaine use, I used to see cocaine chest pain all the time. First guy I ever saw with a cocaine-related heart attack was a Navy sailor. When I was a medical student, we took care of him on the ward. He was 27 years old. So this is an article here, if you're interested, International Journal of Molecular Science, Acute and Chronic Effects of Cocaine on Cardiovascular Health. And I will summarize that here for you. So cocaine kills you in a lot of different ways. This is a little chart that will kind of demonstrate that. So acutely, obviously, it raises blood pressure, sometimes really impressively, like well over the 200s, over 120s I've seen on a number of occasions. But it also depletes nitric oxide. It leads to vasospasm. So if an artery, you may not have atherosclerosis in your artery, but if it spasms down, obviously the diameter of that artery is going to be compromised. Sometimes it can spasm down all the way to the point where there's actually no blood flow, like distally to that. It's basically the same as having a atherosclerotic blockage that ruptures, in that like there's no blood flow going past that obstruction. These guys sometimes come in with ST segment elevation. It looks just like the EKG that I showed you guys earlier. It's just the mechanism is a little different. The treatment's obviously a little bit different. These guys don't benefit from stents because there's nothing to stent, so they need to have their arteries relaxed a little bit. We use a number of different medications to do that. Because of the big catecholamine surge, like these guys are obviously, they're prone to cardiac arrhythmias. So many of them, many cocaine-related deaths are from cardiac dysrhythmias. So ventricular fibrillation, ventricular tachycardia, that just decompensates and then they die. The other thing, though, is that chronic use of cocaine is obviously terrible for you in a lot of different ways, but it's particularly noxious to your endothelium. So it accelerates just the regular development of atherosclerosis. And so, I had an attending tell me years ago that, guys that regularly use cocaine have arteries that look 20 years, they look like the arteries of a man who's 20 years older on average. And I think that's probably true. So it can certainly kill you acutely when you use it, but then it can also accelerate the development of atherosclerosis with chronic use, and you can still die prematurely from regular heart disease, from plaque rupture. Even if you quit using cocaine, 10 years ago, the damage obviously has been done. And with our NBA friend here, there's no way for me to know whether this was acute toxicity or just complication from chronic. I don't think his actual autopsy report has been released, but if it is, I'll take a look at it, and if you guys are interested, I can review it. But it's his cause of death was thought to be atherosclerotic heart disease. So he definitely had at least some degree of atherosclerosis, and his history of cocaine use certainly was not helping him out in that department. Okay, so the question is, how do we detect early atherosclerosis? And if we do detect it, what do we do about it? So, as I mentioned earlier, if you're asking yourself the question, do I have atherosclerosis? Let's say you're a 35-year-old male. You don't really have any significant problems. You don't have an outstanding family history. You're not perhaps in peak shape. You're not, maybe not in the best shape that you'd like to be in, but you're reasonably healthy. Odds are overwhelming. The answer is yes. You already have atherosclerosis. So the question really isn't like, do you have atherosclerosis? It's how bad is it? How aggressively do I need to treat that? Because, and I understand this. A lot of guys are not excited about being put on a statin medication or any other kind of prescription drug, especially at an early age, if they don't necessarily need to do that. So that's a tough question to answer. It's something, that you have to discuss with, that's between you and your doctor. And, your situation might be different than my situation or somebody else's. So anyway, let's look at what's out there in terms of trying to kind of sort this out a little bit. Now, as I mentioned earlier, you could make the argument that because atherosclerotic disease is so prevalent, let's say you're a middle-aged man and you're completely asymptomatic, there's a strong argument there that you don't need to pursue any of these tests. There's 3 tests I'm going to talk with you about that you don't need to pursue any of those. You need to look at your risk factors, blood pressure, inflammatory markers, and your lipids, and you need to treat those aggressively. And there's good data here. This is from the Korean Journal of Circulation, even back to 2006, where there was, these are all different studies that had been done prior to this, looking at the relationship between LDL levels, so LDL-C levels, and then the incidence of both fatal and non-fatal coronary artery disease across multiple studies. And you can see there, they've got it all plotted out. The higher the LDL, the higher the frequency or the prevalence of atherosclerotic heart disease, episodes, so fatal or non-fatal. So you could look at yourself and say, like, listen, I've had an LDL of 150 for the last 10 years. Every time I check it, it's about 150. It's not super high, but it's also not, certainly not optimal. I think you can say pretty safely at that point, based off of these studies, you very likely have atherosclerotic disease, and you probably should do something about that. You don't need to have additional testing. But testing can be useful. And the way I look at it is, this is your body. And so I think you have a right to have as much information about it as possible. And certainly if you're paying for it out of your own pocket, I don't think it's right to deny you one of these imaging tests if you want to have it. work with a provider who understands these tests and and especially one that understands the limitations of these, because that's actually what I want to talk with you guys about a lot. These tests can be useful, but they're not perfect, and they have some of them have some pretty serious flaws that you need to understand that going into it, because you certainly could end up with a false sense of security if you have one of these tests done and it's perfectly good. It does not necessarily mean that you don't have atherosclerosis. Okay, so let's talk about that a little bit. This information I'm going to give you guys is relatively hot off the presses. It's a January 24 article from Atherosclerosis, Thrombosis, and Vascular Biology, assessment of subclinical atherosclerosis in asymptomatic people in vivo, measurements suitable for biomarker and Mendelian randomization studies. What that means is they looked at all these different ways to assess for early atherosclerosis. All of them have strength and weakness, but they honed in on 3 that seem to be the most useful and seem to have the highest correlation with future events. And so that's what we're going to talk about. Again, spoiler alert, they basically came down to looking for carotid plaque, so plaque in the big arteries in your neck that go to your brain, looking for plaque there. They also talk about a coronary artery calcium scan, which is performed in a CT machine without contrast. Those are gaining in popularity. They're cheap. They're getting more and more accessible. So we'll talk about that a little bit. And then one that you may not have heard of, but one that I do quite a lot, and most both clinic and hospital-based physicians do, which is an ankle brachial index. So I'll show you what that is here in just a second. And that's the cheapest, the easiest one. Probably the least useful one, in my opinion, just because you have to have fairly advanced disease, and so it's perhaps not the best for younger people. All of these tests, they said, are good for people who are, quote, middle-aged, and for older people. If you're a young person in your 20s, perhaps in your, under the age of 40, we'll say, there's just not good data to tell us like which one of these studies is the right one for you. I have my own personal thoughts about that, and I'll share that with you here in just a sec. Okay, so let's talk about carotid plaque. 3 main ways to check for it. Ultrasound can be very useful. I do occasionally do those. CT scans can be very helpful, but these are CT angiograms, so they involve IV contrast. They squirt through your veins, and then they take with some very sophisticated software, take some really nice images, and they can detect plaque quite easily. There's a lot of data on MRI. MRI is not readily available for a lot of people. It's very expensive. I'm really just not going to touch on that today because it's not likely that you're going to be able to get access to that. So this is what atherosclerosis looks like on an ultrasound. So these little arrows here, you can actually, these are actually pretty cool pictures. You can actually see the plaque there. The black space, that's the artery itself. So there's blood rushing through there. You can see the artery wall here, and then at these different points here where the little white arrows are, you can see the buildup of plaque. Very helpful. CT is probably the modality in the emergency department that I use the most because I work up a lot of people with strokes. And again, you can see some really nice images here. You can see the carotid arteries here bilaterally, and then where the arrow is pointing, there's contrast going through the vein here, or excuse me, the artery, and you can see that it gets really tight and stenotic in there. You can actually kind of make out the shape of the plaque that's there. So, the downside to CT is that there's obviously increased cost. There is not a huge amount of radiation, but there is a dose of radiation that is something that some people may think about, especially if you've had a lot of CT scans in your life. You probably need to be aware of that. Ultrasound obviously has no radiation. It's generally less expensive, but not quite as sensitive as a CT scan. So they're both good tests. Talk with your doctor if you're interested in pursuing that. As far as how useful this is, these are fairly useful. So these are multiple different studies that looked at the hazard ratios of the presence of atherosclerotic plaque within your carotid arteries. Now, hazard ratio, so think about that's like the relative risk of an event occurring in a treatment group compared to a control group. So if you're doing a clinical study and you give group A a drug and they die at twice the rate of the placebo group, they would have a hazard ratio of 2. If they were equal, if both groups were the same, basically no effect from the drug, hazard ratio would be 1. So anything above 1 would suggest that there's an association. And if we look down here, there's A and B. A is the hazard ratios with atherosclerotic plaque in the carotids and relationship to stroke. And then down here, B is the relationship of or the association of carotid plaque on ultrasound and the risk of having a cardiac event, so a coronary event, a heart attack. And you can see the hazard ratios, almost all of these are above 1. So as you can see, these tests are pretty useful. They're not perfect, but certainly can give you a lot of good information. If you've got carotid plaque, the odds are high that you're going to have coronary plaque. Okay, what about coronary artery calcium? So this is an image here. This is really severe. Yeah, triple vessel calcium found on a non-contrast CT scan. The American College of Cardiology, the American Heart Association are all in agreement that having any level of coronary artery calcium is abnormal and is something that should be treated either with lifestyle intervention or with statin therapy. So what you want is a coronary artery score of 0, no plaque. The other thing that's important to mention is it's not the calcium in the artery that is particularly dangerous. So people do get kind of obsessed about their calcium score. The score can change over time. It usually goes up. But for example, like being on a statin will make your coronary artery calcium go up. Elite athletes tend to have more coronary artery calcium. It's not the calcium, though. The calcium is a marker of plaque. And in particular, what's important is that calcified plaque is advanced plaques. Remember, I showed you that previous diagram, that with where atherosclerosis progresses over time, the presence of calcium within the plaque that can be detected on one of these scans, that's a late finding. Okay? So what it means is if you've got detectable calcium in your arteries, so not only do you have some calcified plaque likely, what is concerning, which could actually concern you more in many ways, is the fact that you actually have, you likely have a lot of soft plaque, which is non-calcified plaque. And it may seem a little counterintuitive, but it's this soft, non-calcified plaque. It tends to be more inflamed, and it also tends to be more prone to rupture. So it's not these like rock hard calcified, 50% plaques that are just sitting there like a boulder that necessarily is the plaque that's going to kill you. It might be the 40% soft, squishy, inflamed, and necrotic plaque that has no calcium in it yet. That's more prone to rupture, and that's the one that gets you. So that's really important. Like that is one of the big limitations with this test that I talk about a lot with my patients, but I don't think is explained well enough to people because, I do run into a lot of folks who are like, man, I had a coronary artery calcium score 0. I'm good to go. My LDL is 180 and I've got a CAC score of 0. I don't have heart disease. That's not what that means. That by no means can you say that. What it means is you have no coronary artery calcium. Period. That's all that means. So you absolutely can have a significant amount of soft plaque. And this is a great case study here that was published in the DeBakey Cardiovascular Journal not that long ago, which this illustrates this perfectly. So obstructive coronary atherosclerosis in a patient with a calcium score of 0. It says it right there. So this is a female patient, 62 years old, morbidly obese, hypertensive, hyperlipidemia. We don't know for how long, but presumably for quite a long time. Came in the ER because she had what they called atypical substernal chest pain and some shortness of breath, had been going on, off and on for 6 to 8 weeks, was concerning enough that this lady was seen by cardiology and underwent a pharmacological stress test. And sure enough, on the stress test, she had this big what they call a reversible defect, which looked very suspicious for ischemia in the LAD distribution, so left anterior descending, the big one, okay? The thing that caused a little bit of confusion and ultimately led to this write-up was that in the course of these PET scans, they do get a calcium score. Her calcium score was 0. So they thought, well, okay, maybe our stress test is wrong. Maybe we had a fault. Maybe this is a false positive, and really didn't know what to do with her. So ultimately, she underwent a cardiac cath, so invasive coronary angiography, lo and behold, this 62-year-old lady with a CAC score of 0 had a 90% proximal LAD lesion, okay, the old widowmaker, and ended up getting a drug-eluting stent to that. 90% proximal LAD, a super high-risk lesion, something that would have taken this lady's life very likely if it had not been picked up here. But again, if she had just gone to her doctor and had a CAC score of 0, she could have been, and the physician as well, lulled into this false sense of security and, would have been like, well, maybe we don't need to be as aggressive about treating your hyperlipidemia and your hypertension and your obesity. And maybe, maybe you're one of the lucky few that can be sort of, metabolically unhealthy and get away with it. Well, no. I don't think there's very many people that can actually do that. So just keep that in mind. I'm not trying to persuade you not to get one of these coronary scans. I mean, I've gotten one in the past. I've gotten 2 actually in my lifetime, but just understand the limitations of it. Okay. It's a test that if it's 0, that's good. Obviously it has a good prognosis. It means that the chance of you having a myocardial infarction in the next 10 years is vanishingly low. It does not mean you don't have plaque. And it doesn't mean you're not going to have a myocardial infarction at some point down the road. Okay. So just understand that. It's like with all tests. There's strengths and weaknesses to all tests, and it's important that you understand those before you get them. The corollary with this is coronary CTA, which is a superior test really in all ways. So that's a test. Obviously it detects coronary calcium, but they use intravenous contrast, so you can also detect soft plaque. And so it can be pretty useful. I've really been wanting to get this available in the emergency department. It has a really good use case in the emergency department for people with chest pain to sort of rapidly rule out a coronary cause for their pain. I've yet to work at a place that has one, but this is a well-validated test in that area. The advantage of this, not only does it pick up soft plaque, as the software gets better and the resolution of these scans gets better, is you can actually look at the plaque morphology, because not all plaques have the same risk of rupture. So ideally, we want to identify high-risk plaque and intervene perhaps more aggressively. So we want to look at the morphology. We want to look at if we can measure the fibrous cap, which is obviously what covers it, we would like to see a nice thick fibrous cap. You don't want a thin, flimsy fibrous cap. The necrotic core, so there's just area of like dead foam cells and other debris in there that is highly inflamed. You can not only measure the size of that necrotic core, but if that necrotic core is very close to the fibrous cap, then that's a higher risk lesion as well. It can give you some additional information, and I think as the technology gets better, this will be even more useful. It's obviously much more expensive. There's more radiation. It involves intravenous contrast. But even this test, this test can miss a significant coronary artery disease. You're like, well, how is that possible? I mean, we're squirting dye through an artery. If there's a plaque there that's intruding into the lumen, we should be able to see it, right? Well, yeah, actually you should. But here's the problem. For a lot of people, and especially early on in the disease, the plaque does not necessarily compromise the diameter of the lumen. So there's this phenomenon called positive remodeling, where basically the artery, it's doing its best to maintain the diameter of the lumen. So, which by the way, when the dye goes through there, that's what the scan looks at. It looks at the diameter of the lumen. And so as you can see in this diagram here, where it says, you can see the lumen here in this positive remodeling, they're roughly the same size between these two vessels here, but this atherosclerotic plaque, it grows into the wall, and then the wall kind of balloons out, so it's growing outward, and that will happen to a certain extent, to the point where it can't do it anymore. And then, as the plaque grows, only then will it compromise the diameter of the lumen. So for a long time, you can be sitting there with this really big atherosclerotic plaque that, when the radiologist goes to read your CTA, and looks and measures the diameter of the lumen there of the vessel, it's going to look fine. It's going to look fine. Might have some little irregularities in it, but it's not going to raise any eyebrows or raise any alarms. But the fact is, there's going to be significant plaque there. So the kind of the gold standard, to detect this, which is is not commonly used is obviously invasive coronary angiography with an intravascular ultrasound. So you got a cath probe. They feed the wire up there. It has a little tiny ultrasound on it. The pictures are pretty cool. You can actually look and see, you can see the plaque like invading into the vessel wall. You can see it kind of ballooning out there. And that's one way that this can be detected. But that's not commonly used. That's not routinely used, at least from what I've seen. You cardiologists out there that are listening to this, if there's any of you, please feel free to correct me on that if that's not the case anymore. And then finally, let's touch on this ankle brachial index. Again, I do this all the time in the ER. If I need to detect compromised blood flow to an extremity, like usually the foot. So all this is, you're taking a blood pressure in the arm, and then you take a blood pressure down above the ankle, okay, and you make a ratio. So the systolic blood pressure at the ankle goes on top, and the systolic blood pressure goes on the bottom, the numerator and denominator. So this is a little picture here. So it should be above 1. Your ankle brachial index should be 1 or higher. As it starts to go down, then that would suggest that there's some sort of impediment, right? If the blood pressure is significantly lower in your leg than it is in your arm, there's something wrong. There's an obstruction there of some kind. It should be roughly the same. And again, this has here are these hazard ratios here, looking at ankle brachial index, and all of these. This is related to coronary events. There's a strong association, obviously, between those two. So if you have peripheral vascular disease, which is what this detects, then yeah, the odds of you having coronary artery disease is quite high. So this is an easy one, actually, that gets done in doctors' offices. Again, you have to have pretty significant plaque, usually like in the iliac vessels or the femoral arteries, and it can be picked up that way. But sometimes this can be like subtle changes over time as you get older. This could be one of the ways that you pick up on the subtle development of atherosclerotic disease. And this one doesn't cost anything, really. All these other tests can be kind of expensive. This is cheap and easy, but it also is probably the least sensitive out of all of them. So, which doesn't mean it still doesn't have its uses. So those are the 3. So you can look at the carotids. Okay, you can look at the coronary arteries, specifically with either a calcium score, or if you don't mind paying a little bit more, having more radiation and an IV, you can get a CTA, get a much better look at the anatomy, or you can do one of these ankle brachial index tests. You also have to think about, like, what are you going to do with this information, okay? So let's say that you find that you've got, let's say you do a CTA, or you do your coronary artery calcium, and you've got detectable plaque, whatever that might be. So let's say you've got 20, 30% lesion somewhere in one of your coronary arteries. Is that going to change what you're going to do? Well, that's going to be up to you, but it still comes down to aggressive risk factor modification, whether you have that knowledge or not. I have found it useful to motivate patients. For atherosclerosis and plaque, it can seem kind of abstract to a layperson. Why do I have to do all this stuff? Why do I have to take this medication? Why do I have to exercise every day and watch what I eat? I feel fine. Why do I need to do this? When you can show them a picture, hey man, this is your right coronary artery, and guess what? You've got a 30 or 40% blockage that's growing there. All of a sudden, you can kind of see the gears turning. The little light bulb goes off, and like, oh, okay. And it can be, in my opinion, it can be a really useful motivator for them to stick to their program and to continue to make those healthy lifestyle choices, which again boil down to a healthy diet. Probably Mediterranean diet has the best data behind it. It's going to be aggressive management of your blood pressure, either with or without medications, ideally with a good blood pressure that averages under 120/80. It's going to be lowering your ApoB. That target can be up to you and your doctor. I think lower is better for the most part. Certainly, if you can get your ApoB, if you have no other risk factors, nothing else wrong with you, and you're relatively young, you get your ApoB down around 70, you're probably doing pretty well. Okay, I have got mine significantly lower than that because I have a little bit of detectable plaque in my right coronary, and as I've talked about before, I have very high lipoprotein A, Lp(a). So just another quick plug: if you've never had an Lp(a) level, you should get it checked. You should get it checked, and if it's normal, you don't need to check it again. But if it's elevated, you need to treat that a bit more aggressively, in my opinion, and you otherwise would if you had, say borderline cholesterol. So a lot of coronary artery disease comes down to, or a lot of, I should say, the slowing of coronary artery disease comes down to optimizing. It's not just lipids and blood pressure, but metabolic health, right? We want to make sure that we're insulin sensitive. We want to make sure that we've got low levels of systemic inflammation for the most part. So I shoot for 10 to 15% body fat in my patients. That's what I recommend. I realize for some of you that are walking around at 35% body fat, that can seem kind of daunting, but listen, that's what you need to at least try to achieve that, if even if you don't. But if you go from 30% or 35% body fat and you go to 20%, that's still great. Like, you've done yourself a real service by doing that. So that's all I have for you guys today. I just when I saw that basketball player died at such a young age, it kind of prompted me to want to talk about this again, because I deal with a lot of late stage atherosclerosis in my emergency medicine practice. I work with a really good group of cardiologists that we're always treating, in my opinion, we're treating the end game there, when really I would really love it if patients understood this disease a little bit better, doctors too, and started thinking about this. I mean, honestly, in their teen years, maybe that's not realistic, but certainly when you're in your 20s, you should be thinking about these lifestyle changes, thinking about your cardiac risk factors, and thinking about things you can do so that 30 years down the road, 20 years down the road, or in the case of this, professional athlete, 10 years down the road, somebody doesn't find you dead at home because you haven't answered your phone for a few days from a heart attack. And that's, not trying to be dramatic about it, but that's what happened to this young guy. So I don't want that to happen to you guys. So love to hear your comments on this. We'll catch you guys later. Bye. All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service because I genuinely believe in it, and not because I'm being paid to endorse it.